Hello, this is Stephen-Castro, and I'm going to do a presentation on the Perfusion exemplar of CBA and TIA. This presentation will cover the information that is in your book in Chapter 45, Care of the Critically Ill Patients with Neurologic Problem, that begins on page 927. Some interrelated concepts for this subject matter may be mobility, sensory perception, and cognition. Our primary concept is perfusion, and the definition for perfusion is the flow of blood through the arteries and capillaries, delivering nutrients and oxygen to the cells. We have two subsections: peripheral perfusion, and that's to the extremities, and central perfusion, which is your major organs, including heart, lungs, and brain. Our exemplars for perfusion include TIA and stroke, coronary artery disease, and dysrhythmias. The learning objectives are located in your course shell. Review the perfusion concept introduction. I'll have that posted. We also would like for you to review the lesson plan on perfusion, which includes your required readings and any additional information you might need to review. Also review your student learning outcomes for the concept and these exemplars. We are going to begin with TIA, or Transient Ischemic Attack. A transient ischemic attack, otherwise known as a TIA or mini-stroke, can be a warning sign for an ischemic stroke. It's a brief interruption of cerebral blood flow, and the symptoms will typically resolve in about 30 to 60 minutes, often before the patient arrives at the hospital. Some of the manifestations for TIA include visual deficits such as blurred vision, double vision, possible blindness in one eye, and tunnel vision. They may have some motor deficits such as ataxia or weakness, sensory perception issues such as numbness or dizziness, and speech difficulties such as aphasia. A client who has TIAs inherently has an increased risk for developing a stroke. And repeated TIAs can also lead to brain tissue damage. On admission to the ER for evaluation or the emergency department, these clients are worked up similarly to a stroke patient, which will include labs, CT scan, and a complete neurological assessment, which we'll go into some details later. TIAs often lead to ischemic stroke, so it's important to identify any modifiable risk factors and encourage healthy lifestyle options, reducing blood pressure, taking an aspirin or antiplatelet medication, controlling diabetes. Doing these measures will help prevent future strokes. A stroke is a lack of blood flow to the brain or lack of perfusion to the brain. The National Stroke Association really wants you to think of this as a brain attack. They want clients to seek treatment immediately because the earlier they seek treatment, the better outcomes they have and the less permanent disability they are likely to have. There are two types of strokes. You have ischemic, which is lack of blood flow, or hemorrhagic, which is a bleed. Both of these cause lack of perfusion to the brain tissue itself. Ischemic has thrombotic and embolytic, whereas hemorrhagic has aneurysms, AV malformations, and hypertension. So your ischemic stroke is the lack of blood flow in the arteries of the brain. Two underlying causes. You have a thrombus, which is a blood clot, or you have an embolic stroke, which is basically a dislodged clot. A thrombus is the most common cause of a stroke, and it's usually related to atherosclerosis. And you see those changes within the tiny vessels or the tiny arteries of the brain. Either a fatty plaque will bust loose and develop a clot, or the plaque themselves will cause ischemia. An embolus is still a thrombus. It just starts somewhere else in the body and travels to the tiny little arteries in the brain. The most common site of where it starts is in the heart, and it's typically related to atrial fibrillation, although there's other conditions that can lead to an embolic stroke. A hemorrhagic stroke is a bleed in the brain. Usually there's some type of integrity issue with the vessel walls in the brain, and that will lead to some type of a bleed within the brain, typically in two different spaces, either the intracerebral area or the intracerebral hemorrhage, or it causes a subarachnoid hemorrhage. Uncontrolled hypertension is one of the major causes of an intracerebral hemorrhage. A subarachnoid hemorrhage is bleeding into the subarachnoid space in the brain. The most common causes for subarachnoid hemorrhage are the ruptured aneurysm or that AV malformation. An aneurysm is a weak spot in the vessel wall, and it starts to balloon out and it may eventually rupture, causing the hemorrhage. Whereas an AV malformation is where the vessels themselves are actually malformed, and that usually happens with embryonic development. It's important to identify clients who are at risk for stroke. It's basically three categories: those that can be modified with lifestyle changes like smoking cessation or losing weight, or those that can be medically managed like controlling hypertension. And then there's the other group of non-modifiable, with those that have genetic issues. I want you to take a look at the chart at the bottom of page 930. It's the chart 45-2. It lists some modifiable risk factors for developing a stroke. While obtaining a history is important, it's extremely important not to delay care. We really need these clients that exhibit any of the clinical manifestations for stroke to get to a certified stroke center as soon as possible. That way they can begin the evaluation and start therapy if needed. So when you begin your physical assessment, always going to rely on those ABCs, but we're definitely going to focus on those neurological exams, level of consciousness, and the NIH stroke scale, which I'm going to talk about here in a second. But don't forget to check for hypoglycemia, because hypoglycemia can mimic stroke clinical manifestations. The NIH stroke scale is a special assessment that they've developed for clients who exhibit clinical manifestations of stroke. I want you to be familiar with the NIH stroke scale. You don't have to memorize it, but please be aware that 40 means they have the most severe deficits and 0 means no deficits. Clients with a stroke may have cognitive changes. Remember, cognition is one of those overlapping concepts that we talked about earlier. There are a list of different potential cognitive changes depending on whether the stroke happened in the left or right hemisphere in your book. It'd be a good chart to review. It's important to do a thorough mobility assessment to kind of determine where the injury is in the brain. If the injury is in the right side of the brain, you'll typically have effects on the left side of the body. And if it's on the left side of the brain, you're going to have effects on the right side of the body. Sensory perception is how patients will process touch or stimuli, even painful stimuli. Typically, they have these types of symptoms on their affected side of the body. So if it's a right-sided stroke, you'll see them on the right side. If it's a left-sided stroke, you'll see them on the left. Clients with strokes may have impaired cranial nerve function. And while you don't have to memorize all of those 12 cranial nerves again and the assessments go along with them, just apply what you do know. And we know that they can have difficulty swallowing and are at high risk for aspiration. Clients that have a stroke often have those underlying cardiovascular issues such as murmurs, dysrhythmias, those clients with those embolic strokes, and hypertension. Please make note of the blood pressure because it kind of has to be in a therapeutic range to maintain perfusion. While there's no definitive lab for a diagnosis for stroke, they will do baseline assessments, including a CBC and an electrolyte panel. They'll also frequently do a coagulation study prior to starting any type of fibrinolytic therapy. The CT scan or the CAT scan is kind of the gold standard for clients who present with a stroke or stroke-like symptoms. It can quickly determine whether it is an embolic stroke or a hemorrhagic stroke fairly quickly. Other scans may include an MRI, MRA, or even ultrasounds of the carotids. Once you've collected all your data from your assessments, it's time to prioritize that information and look for any potential problems that your client may have as related to perfusion or stroke. The goal for acute stroke, whether it's hemorrhagic or embolotic, is to restore perfusion, cerebral perfusion. So depending on what kind of stroke it is and where it is and the extent of the stroke is going to kind of determine the interventions that are available. For ischemic stroke, because the underlying cause is a thrombus or an embolus, the goal is going to be to establish reperfusion into the brain, so they're going to have to eliminate those clots. So that's going to be either IV fibrinolytic therapy or endovascular interventions. TPA is the medication that they use for fibrinolytic therapy or the clot busting therapy. There are some very specific indications and contraindications with this medication, and please review those prior to the exam. There's a 3-hour window from the time of onset as well, which is why it's important to get that CAT scan as soon as possible. Endovascular interventions include the intraarterial thrombolysis, which there is a 6-hour window with that. So again, time is important. An embolectomy, which is removal of the clot, as well as a carotid artery angioplasty with stenting, which is where they place a stent to reopen up the vessels for perfusion. The hemorrhagic stroke, on the other hand, is related to a bleed in the brain, whether it's an AV malformation or an aneurysm. This can lead to increased cranial pressure, as well as some of the procedures for ischemic stroke might lead to a bleed for increased cranial pressure. So it's very important that you review ICP and your interventions. It's important to monitor for other complications such as hydrocephalus, which is fluid on the brain. It's cerebral spinal fluid that has an occlusion so it can't get out, so there's additional fluid on the brain. Cerebral vasospasm, which can cause ischemia to the brain tissue, as well as rebleeding. Additional pharmacological therapy will be needed for stroke clients, including those antithrombotics, the anticoagulants, some calcium channel blockers, pain or anti-anxiety medications, and stool softeners. I'd like you to review this list and understand why we're giving these to our clients ongoing after stroke. The overall goal is to return the client to pre-stroke functional ability. But before that happens, we need to address a few things of safety for our client. Maintaining MPO is one of those because they're at high risk for aspiration. So we need to make sure there's a swallow study done, support those deficits, and also additional thrombus prevention. Alternative communication efforts might be needed for clients who have had a stroke that affected that particular area of their brain. The left is the speech center for most people. There is a table 45.3 in your book. Please review that, as well as those guiding principles that are listed on 938. Some clients may have some changes in their sensory perception, especially those clients that have had a right-sided stroke. They may cause some sensory deficits, so we need to help them adapt to those deficits. Approach them from the unaffected side where they can see you, or place objects in their clear field of vision where they can see them. The Joint Commission is an accrediting body for hospitals. They also do specific certifications such as stroke care centers and cardiac centers. They have a list of 8 core measures for ischemic stroke care on page 939. Those are in line with that evidence-based practice for best outcomes. Ideally, we need to transition our clients to home care, and this is going to have a lot of education implications on disease prevention, disease information, and self-management. It's also going to include that FAST exam because they're at higher risk for developing another stroke. This brings us to our final step in the nursing process, the reflection or the evaluation of our nursing interventions. Ideally, our client would have had adequate cerebral perfusion. They're able to maintain blood pressure and blood glucose, able to have some self-care, effective communication, and adequate nutrition without the risk of aspiration.